thrust and non-thrust manipulation for inversion ankle sprains. Inversion ankle sprains are common injuries that tend to heal well on their own, generally resolving with only residual symptoms after 1 month. Unfortunately, these injuries have a nearly 80% recurrence rate. Further, depending on the activity level of the patient, it may be critical to speed this regular recovery interval. According to some reports, these injuries are known to respond well to conservative treatments, including manual therapy. Early active ankle mobility exercises are well studied and generally quite successful in the treatment and rehabilitation of inversion ankle sprains. The authors contend that combining manual therapy and active ankle mobility exercises could have additional benefits to those who have encountered an acute ankle sprain. Thus, they sought to develop a clinical prediction rule to identify those patients with inversion ankle sprains who might benefit the most from these combined interventions. Pertinent results: 75% of patients in the study had a successful outcome using the study protocol. See study methods below for definition of a successful outcome. 55% of those with treatment success had it at the time of their second visit, with the remainder having success at their third visit. There were no adverse events. Scores on the ankle-specific functional and mobility outcome measures employed found that the group that had successful outcome from treatment had a significantly greater degree of improvement than the group that did not have success with the treatment. Although this was not the case for pain scores, 4 variables were identified. If a patient had 3 of them in place, the probability of successful outcome using those treatment methods was 95%. These variables were: 1. Symptom worse withstanding. 2. Symptoms worse in the evening. 3. Navicular drop greater than or equal to 5.0 mm. 4. Distal tibiofibular joint hypermobility. The accuracy of the clinical prediction rule was highest with 3 of these factors were in place, and lower with 2 variables, 78% probability of success, or 4 variables, 56% probability of success, present. Clinical application and conclusions. It is of great importance to formulate clinical prediction rules to arm clinicians with the knowledge of which patients are most likely to respond to certain treatments. This study provided the foundation for a potential clinical prediction rule for manual therapy and early general mobility exercises for ankle sprains, indicating that if patients had at least 3 of the following 4 variables, they have a 95% likelihood of success. 1. Symptom worse withstanding. 2. Symptoms worse in the evening. 3. Navicular drop greater than or equal to 5.0 mm. 4. Distal tibiofibular joint hypermobility. If readers have patients with all 4 or 2 or fewer of these variables in place, it may be advisable to consider other treatment methods. Knowing the importance of the above-mentioned variables is also of importance in directing items in the patient history, symptoms worse withstanding or in the evening, and physical examination, using the navicular drop test and evaluating for distal tibiofibular joint hypermobility. Study methods. 85 consecutive patients were admitted to the study. Inclusion criteria included age 16 to 60 years, ankle pain consisting of a grade 1 or 2 ankle inversion sprain in the past year, pain rated at least 3/10. Patients did not require x-rays as per the Ottawa ankle rules. Patients saw one of 9 physical therapists at one of 4 different sites, who used a standardized and extremely thorough patient history and physical examination. Patients completed several baseline outcome measures, including the numerical pain rating scale, NPRS, foot and ankle ability measure, FAAM, the lower extremity functional scale, LEFS, and the Beck Anxiety Index, BI. These outcome measures were also completed at a final examination. Just before the second treatment session, patients completed a global rating of change GROC scale to see if they had clinically meaningful improvement. This occurred at the third visit in necessary as well, if patients were at least quite a bit better, according to the GROC after the first treatment. They were considered a treatment success, and their participation in the study was complete. The rest had a second treatment session and then attended a follow-up visit, where they completed a second GROC. If patients were again at least quite a bit better on the GROC, their treatment was a success, and the remaining patients were considered non-success outcomes. 23 of the patients underwent a second clinical examination due to availability of a second examiner. A standardized treatment was given in the first 2 sessions. There were 4 components to the treatment. 1. Ankle, foot thrust, rear foot distraction. Proximal tib fib posterior to anterior with a maximum of 2 attempts, and non-thrust manipulation. Anterior to posterior talocrural. Lateral glide, aversion rear foot, for 5 by 30-second bouts of grade 3 or IV joint manipulations. 2. General mobility exercises, general ROM exercises including Achilles tendon stretching, alphabet exercises, and ankle eversion and dorsiflexion self-mobilizations. These were done in the clinic and were also to be done daily at home. 3. Advice to maintain usual activity within pain limits. 4. Instruction regarding ice and elevation.